Good afternoon. I welcome you to the CCR of presented by Department of Psychiatry and National Drug Dependence Treatment Center. The topic for today's presentation is externalizing disorders and drug dependence and interplay. Externalizing disorders basically refer to a range of behavioral problems like bullying or conduct disturbances which predispose a child or adolescent towards substance use. Basically, that's a aim of presentation for today's CCR from the department. I'll request Professor Sonali Jhanji to take over.
Good afternoon to everyone, and thank you, sir, for the introduction. So as sir has introduced topic that we are presenting a case of drug dependence with externalizing disorders. And just to clarify what externalizing disorders are further, so basically when you see common mental disorders in childhood and adolescence, we can think of two broad dimensions, that is the externalizing and the internalizing dimension. So what we mean by externalizing dimension, when the problematic behavior is directed outwards in the form of aggression, impulsivity, and rule breaking, and when the same emotions and behaviors are directed inwards in the form of anxiety and depression, so those are known as internalizing disorders. So externalizing disorders include attention deficit hyperactivity disorders, conduct disorders which present with a multitude of symptoms which are listed here, and we are presenting a case of conduct disorder in this clinical combined round. And the oppositional defiant disorder is largely on the same spectrum as conduct disorder, but will not have rule violations, but have a lot of disobedience and defiance, but not rule violation. Now these disorders are very common, are relatively common, with estimates ranging from 7 to 10%, and they are commoner in males relative to females. Now, how are they relevant to the context of drug dependence is that externalizing psychopathology is a very robust and prospective predictor of a variety of early onset substance use behaviors, and also related to the degree and severity of substance use involvement. So the case that we're going to present today has a multitude of diverse conduct symptoms, multiple risk factors, very severe dependence, and also a lot of complications. The patient also uses ketamine, which is an anesthetic drug, which is not commonly seen in our, the abuse of the drug is not commonly seen in our center. So I'll request Dr. Abhishek Gupta, who's a DMSR with us, to present the case history. Dr. Abhishek.
So I'll begin with the case history. Patient is a 25-year-old married male. He's a graduate and unemployed currently. He's a resident of Bulandshahr, and his chief complaints are tobacco use in the form of BD smoking for past 15 years. Inhalant use, he has used it for 3 years, and his last use was 11 years back. Cannabis use in the form of ganja for past 8 years. Ketamine use for past 7 years. Street heroin use for past 5 years, and there's history of frequent fights and aggression since the childhood. So when the patient was 7 years old, there were frequent complaints from the school regarding fights, and he would fight his seniors also just for the sake of fun. He was poor in his studies and kept disturbing the whole class. He would bully other children. He would ask them to polish their shoes or threaten them if they would complain to the teacher. So because of all these problems, his school was changed in sixth class, and in the next school also he continued with the same behavior, and he would frequently break glasses, fan, bulbs or tube lights in the school, and he would often burn crackers in the school itself. So at the age of 10 years, the patient started smoking BD with his friends, and gradually his use increased to 7 to 8 BDs per day. And he also influenced his younger brother to start using tobacco. During the same time, he started missing school and kept roaming with his friends in parks and used BD over there and watched movies. He would have frequent argument with the teachers. And on one instance, he went into a female washroom and picked a sanitary pad and started running in the corridor, mocking the teacher. So at the age of 14 years, the patient started using typewriter correction fluid. The method of using inhalant was that he would put all the fluid in a poly bag and then would inhale from it. The effects used to last for 5 to 10 minutes, and uh, frequency of his use increased with time, and would use every 1 to 2 hours in a day. So by this time, he started keeping a country-made pistol also with him. And on one occasion, when his father tried to stop him, he fired a shot at him, and he started getting aggressive frequently on trivial issues. So all these behavioral issues eventually led to the termination from the school again in the 10th class. So at 16 years of age, patient started using cannabis in the form of ganja, and his use increased within 2 months to 5 joints per day. And he entirely stopped using correction fluid by now, and he shifted to cannabis use predominantly, along with the tobacco use in the form of BD. So he also would steal money from the house and his father's pocket to sustain his cannabis use. And 1 year later, he completed his 12th exams, but predominantly by cheating. So at the age of 17 years, patient started using alcohol, and he would frequently use up to 2 quarters of IMFL within the initiation of 2 months. And he started going to female sexual workers also at this age under the influence of alcohol. He had multiple girlfriends by now and would force them often to use alcohol with him. He was involved in high risk sexual behavior in both unprotected and protected manner. So patient also started using ketamine at an age of 18 years, and he started buying from a local chemist shop, and he would spend around 500 rupees on it, while the market value of the vial was 150 rupees. One vial would comprise of 10 ml, and the it would have 50 milligram per ml of ketamine. The patient started using up to 30 ml per day within 4 months of initiating his ketamine use. So he would use it by the mode of snorting, and by this time he would use alcohol in parties only and continued using ketamine and ganja throughout the day. So let us see what are the effects of ketamine use on a single occasion. On initial use, the patient would feel that the body is relaxed and there was decreased sensation of presence of limbs. And gradually, on increasing the dose, he would see the objects in a size of smaller or larger, and there would be misjudgment of the distance also. There would be heightened perception of sound, and there was generalized slowing of all the actions. Later, if we would increase the dose further, so there would be apprehension that I might die, and he would also have tachycardia and diplopia. On subsequent increasing the dose, the patient would develop vomiting. So during this ketamine use only, patient was involved in election with his uncle, and due to his frequent fights, he was booked under Section 307, and uh, patient remained abstinent during this election for 2 months, and he would remain as he would remain occupied in this election related work. He also increased his ganja and alcohol use during this period. Patients started remaining involved with the deviant peers, in which who were involved in activities like drug peddling, thefts, and snatching. He started driving vehicles at a fast speed and eventually met with a severe accident, which led to his fracture of the bilateral femur. So his friends continued providing him ketamine and cannabis use in the hospital as well as in the home. So at the age of 20 years, the patient started using street heroin, also known as smack. He cited the reason as it was cheaper, easily available in his area, and its effects lasted longer than the ketamine. He would use up to 1200 rupees worth of smack within 2 months of initiating it, and it was characterized by craving and withdrawal symptoms such as rhinorrhea, loose stools, yawning, etc. So patient would take money for buying smack by making excuses for repair of bike or college fees. He would break table or glasses by throwing bricks if his mother won't give him the money. He would also sell the household items and utensils from his father, all this to sustain his substance use. So all this substance use eventually led to increase in the aggression with the increasing substance use. He would also threaten of committing a suicide by hanging, or would make hesitant cuts to sustain his substance use. Mother tried to sought treatment for him on multiple occasions, but nothing worked. So eventually, the patient got married in December 2020, and the mother expected him to stop his substance use by now, but the patient continued using substance, and he sold his wife's jewelry also, and he tried to break the locker in which his mother kept money. So the mother called for the police in these instances, and eventually the patient agreed for quitting substance on his repeated persuasion by the mother and wife, and patient came to NDTC on 22 June. There is also a history of occasional use of tablet alprazolam and capsule tramadol whenever patient won't be able to use his primary substance. There was no history of any injection drug use and overdose. There was no history of any mood disorder. This is just a snapshot describing that multiple substances patient was taking any given point of time. In the family history, patient's father was using alcohol in a dependence pattern and had multiple complications related to alcohol use. So there were frequent fights related to his alcohol use, and he would beat his patient's mother also. So patient would try to tackle him and was involved in multiple fights with his father also. And his mother spent most of the time in handling his father, and she was obese also, and there was chronic back pain. So all of this led to the neglect of the children, and the parents were not paying attention towards the children. His younger brother also started using substance under the influence of patient. Currently he is working as a medical representative. He has done B Pharma, and his wife is employed as a teacher. They are married for 7 months, and there are cordial interpersonal relationships with the patient. They are supportive of the treatment and supervises the she is supportive of the treatment, and she supervises his medicine also. Patient has no history of any delayed milestones, no history of any inattention or easy distractibility. He was poor in studies and cleared all his exams by cheating, and there is no history of any gainful employment due to substance use. On general physical examination, patient had nicotine stains on the teeth. There were burn marks on his right hand. Nothing adverse was detected on systemic examination. And on mental status examination, thought content showed that there was lack of remorse. And the speech sample was that मुझे तो टीचर से पंगा लेने में मजा आता था. टीचर को प्रिंसिपल को मैं कुछ नहीं समझता था. एक तो अटेम्प्ट टू मर्डर का केस भी चला है मुझ पे. काम तो बहुत गलत किए हैं पर कभी पछतावा नहीं हुआ किसी बात का. बस मजा आता था ये सब करने में. On motivation, the patient was in action stage of change, and speech sample was नशा तो सब लोग करते हैं. मेरे पापा भी शुरू से पीते थे, मेरे आसपास भी सब दोस्त करते थे, मैं भी करने लग गया. धीरे धीरे शरीर में ताकत ही नहीं रहती थी बिना नशा करे. मुझे तो पहले कभी लगा नहीं कि छोड़ना चाहिए. अभी मम्मी और वाइफ भी बोलते हैं छोड़ने के लिए, और मैंने भी बोला था शादी के बाद छोड़ दूंगा, इसलिए बस इलाज करा रहा हूँ. On there was no cognitive impairment, and it was assessed by the mini mental status examination. The diagnosis is that the patient had opioid, cannabinoids, hallucinogens, that is ketamine, and tobacco independence syndrome. There is also volatile substances and alcohol use independence syndrome, and but the patient was currently abstinent for it. For behavioral issues, the diagnosis is conduct disorder and dissocial personality disorder, and the following criteria were fulfilled for them. There was excessive levels of fighting or bullying, cruelty towards other people. There was repeated lying, truancy from school, unusually frequent and severe temper tantrums. There was defiant provocative behavior, persistent severe disobedience. There was also callous unconcern for the feelings of others, persistent attitude of irresponsibility, and patient had low threshold for aggression, and there was incapacity to experience guilt. Thank you.
So thank you, Abhishek, for the case history. So let's have a quick look at the case highlights. So this case, of the many highlights of the severe drug dependence that he had. So he had a very early onset of substance use at 10 years of age. His father was alcohol dependent, and he was in an environment which had his parents were really largely absent figures, couldn't really supervise. Either of the parents could not supervise him or his brother. So there was poor parental monitoring and supervision. There was extensive diverse symptoms of conduct disorder. He moved around with a very deviant peer group, used a range of multiple drugs together, and was using ketamine for a long time when he presented to us. So when he presented to us, because of the nature and severity of his drug dependence and the conduct disorder, we advised inpatient admission to the patient. However, the patient did not agree for the admission, so we had to handle him on outpatient basis. The family was in crisis when they came to the OPD because the mother was at a wit's end and was telling the patient that she'll either call the police and asking to get out of the house. And the patient himself was because he had dearth of money, he had very severe opioid withdrawal symptoms. He was in a crisis, and he was opioid withdrawal symptoms are really painful, and he was just looking for a way to handle his withdrawal symptoms. So at this point of time, it was very important to offer support and reassurance to the patient that we will take care of your withdrawal symptom. Additionally, the family members were educated regarding the medical model, because there was a lot of expressed anger by his mother and his wife at that point of time. We told him that the patient, what was happening to the patient, is not doing it according to his will. So substance use disorders are very chronic, long-term disorders, and it's beyond the patient's ability to control his actions regarding substance use. So they calmed down a bit, and we told them that we will be starting medication on OPD basis, and you will have to support the patient and don't pass critical remarks at home at this point of time. It was also very important in this history that we simultaneously treat his brother. So he was also initiated on treatment, because since both of them used to use drugs together, and if one of them were using drugs in front of the other patient would never have been able to abstain. So some of the drugs that he was using were very toxic in nature. For example, inhalants use is associated with liver, kidney, CNS, and peripheral nervous system damage. And also ketamine use is associated with a lot of toxicity. So we sent his laboratory investigations to rule out the presence of any physical health damage. Then we had limited, we don't have options for all the drugs, pharmacological options for all the drugs that he was taking. So, for example, there's no defined treatment for ketamine or not even cannabis. So we were targeting his opioid dependence, and we started him on a regimen. Basically, we started him on capsule tramadol to relieve his opioid withdrawal symptoms. But since it's a weak opioid agonist, he was unable to abstain with that. Then we started tablet buprenorphine, which is more potent, and he finally obtained some relief from his from opioid withdrawal symptoms. And then we tapered it off gradually, and then we started him on tab naltrexone after a naloxone challenge test. So basically, naltrexone is an antagonist-based treatment of opioid dependence. So you have to detoxify a patient and then start naltrexone, which is an antagonist at opioid receptors. So if naltrexone is occupying the receptors, if the patient takes heroin or top or any other opioid on top, it's not really going to act. So this was the rationale behind the treatment. And very importantly, uh, it was you had, because he was basically moving around in a very deviant peer group, it was very important to disengage him from that peer group. So we asked him to either change his sim or shut down his phone and not take any calls, because the moment they used to call, he used to go out of the house, and they used to abuse drugs together. Then the involvement of wife in treatment at this point of time was very critical, because he valued her support. And there is a lot of research-based evidence on the importance of giving supervised naltrexone. So if somebody supervises your treatment and administers the drug every morning, there is a more of a chance for the patient to recover, because if he stops taking naltrexone, he loses that protection which is offered from this drug. The patient was also asked about what were his problems, these prominent problems when he, during this process when he was trying to abstain, or he had abstained by that point of time. So he said that I experience a lot of craving, and I cannot resist my peers when they ask me to use drugs. So we gave him distraction techniques to, prevent relapse and also disengage from his peers. So we also objectively confirmed his drug abstinence by urine drug screening by thin layer chromatography, where we found that he's abstinent from opioids and all other drugs except cannabis use and tobacco use, which he continued. Now, it was very important in this patient, given his severity, that we maintain close follow-up with his family member and continually psychoeducate the patient as well as family members about the long-term harms and consequences of the multiple drugs that he was taking. The very important message that we tend to give in such an environment is that even if he relapses, he still has to follow up with us, right? If the patient remains in treatment, we have various treatment options to offer, but if the patient drops out, there's little we can do. So this kind of rapport was built with the family as well as with the patient. We also completed a personality assessment, and in consonance with our clinical assessment, the patient was diagnosed as antisocial personality disorder and also had very high novelty seeking traits, which is seeking new experiences basically. So he was excitable, curious, impulsive, and exploratory in nature, which also contributed to his drug use. Now, the patient has been abstinent for say 1 to 1.5 months, and he really basically has nothing, he doesn't know how to structure his stay. So here's a young man who's just 25 years old, but has been using drug for 15 years of his life, and he doesn't really have any experience of working. So we just initiated a discussion regarding what are the various options that he can occupy himself with, and these discussions are still continuing. Now, it's very important also in the management to place this patient on long-term counseling, because wherever he goes, in whichever situation he goes, these traits of getting into fights or bullying, so these traits will be evident everywhere because they are a part of his personality makeup. So, offering long-term individual psychotherapy goes hand in hand with the pharmacological management. Right. So there is also a lot of research support on why this patient presented with such severe symptoms. So, for example, early age of onset. If you insult a developing brain, it's very very disruptive, and the rewarding and the adolescent brain is very susceptible to the rewarding properties of substances. So, which increases the potential for progression and heavy repeated use. So there's a whole body of research as well which says that because nobody can really say that please don't use alcohol and tobacco at all. So it's almost normative to experiment. So, but if you delay the initiation to beyond 18 years or beyond the time when the whole maturation of the brain has taken place, so that is a preventive measure for substance use. Then the patient was alcohol dependent, and children of alcohol dependence are really from a different class of people in which they are both vulnerable genetically to develop alcohol dependence as well as environmentally to develop substance dependence, because it creates such an environment where there is low parental monitoring, and that is associated with a greater risk of substance use, delinquency, risky behaviors, as we have seen in this case. So, as we've just talked about how conduct disorder predisposes to substance use, so we have some data from our center. So, in a review of clinical records in our center, we have around 723 adolescents from a period of around 11 years, and we found that comorbidity for conduct disorder was 8% in opioid users and 10.8% in non-opioid users. So that means there is a lot of conduct disorder presenting in substance use disorder treatment settings. Right. So, and as I just said that having conduct and also having novelty-seeking traits predisposes to using a range of substances together, as in this case. The other very peculiar presentation was in this case was his ketamine use. So we don't see it very often in our center, and usually ketamine is used recreationally in parties on weekends. So this was a very long-term chronic use, and it's usually seen in individuals who are working in the veterinary setting where it is commonly used as anesthetic agent, and it's also seen in anesthesiologists. And the route of administration, like we have 5 case reports from India and 3 are from our center. So the route of administration in all these cases was parenteral, either intramuscular or intravenous. In this patient, it was snorting, and we don't really have any evidence of what is the best way to treat these. But in these two of these individuals, they were treated with naltrexone and they kind of recovered with it. So it is again a very toxic drug, which I have really listed out. So the patient had normal renal and liver investigations. So physical health damage was ruled out. Now, how do we really prognosticate this case? Obviously, it's a very severe case of dependence with multiple risk factors. There is a high risk of relapse, but then we can institute opioid agonist maintenance, and that kind of treatment also has a very good evidence base of retaining as well as helping the patient to abstain from drugs. He's not able to abstain from cannabis and tobacco, so we can provide him motivation enhancement sessions for the same. What is dissocial or is personality disorder? It's ultimately a lifelong disorder, but it can be moderated. The symptoms can be moderated with individual counseling. As an addiction specialist, though, it's very important to look at what we can work with. So, what we could work with this patient is because he responds to support, both family support and has a rapport with the treatment team, in that he has never missed follow up. So what our achievements in this case are as listed. So one of the most remarkable things was that his mother said that from the time he presented and now, his patient mein zameen asman ka farak hai. But so what we learn from this case is drug dependence, no matter how much severe, is a treatable condition. But he needs to be in continued counseling for his personality disorder. Looking at a broader perspective, taking out from this case is that if a patient presents in a school setting with aggressive behavior, there is a case to intervene at that point of time to prevent this cascade of effects. So that's all I wanted to say. Thank you. You can take the questions. So we can take any questions from the audience. Yeah, so basically, the behavioral intervention that works with children like this is involving the family in the treatment, providing them differential reinforcement. That means that you are rewarding them for the right things and discouraging the negative things. So that is one very important. Then setting consistent limits for the behavior. Like parents tend to give in, this okay if you're acting out so much, okay, take this. So that should not be happening. So consistent disciplining and differential reinforcement, these are two things which work very well in this setting. So any other questions from?
I think one good thing about this patient was that he has been staying with the family, though despite so many conduct disturbances, disciplinary issues, and indulgence with breaking the law. Recently, he has got married and has got reasonably stable relation. I mean, though it's not that old, it's a few months, but that's acting as a support. So that's that has probably helped in the retaining a patient in the treatment also.
Throughout the time that you were telling us his story, what struck me was, of course, his distress. But to be his classmate or his teacher or his sibling is terribly difficult.
Yes, sir. Yes.
And all of us encounter sometimes people like this. What should we be doing? You mentioned they don't engage very much. So this laying down limits and disciplining doesn't work.
So it does work if it is done properly, and the school, they can be very easily detected in the school setting. The one advantage of this presentation is that they can be very easily detected in the school setting. And in fact, I think there is a project going on in our department which is educating counselors about how to handle deviances at this level only. So basically, the whole idea is that this behavior should be nipped in the bud, because once they start acting out, they start getting rejected by normal people. And when they don't find acceptance there, the aggressive behavior increases to attract attention. So it results in a cascade of effects. So actually nipping it in the bud by both by the teacher and by the parents, by enforcing strict discipline, also giving him a lot of emotional support by the parents and supervision, it has a research-based evidence of efficacy.
Thank you.
Yeah, Anju wants to say she works with adolescents.
Children who have conduct disorder, they also have associated, many of them have associated attention deficit hyperactivity disorder. This patient didn't. So that if medication is required, they respond very well to medication in addition to other behavioral interventions.
Any more questions? I think we have also finished our time. I thank you all for your kind attention and attending the program. Thank you.